Hey guys, so today we're going to be doing another mock question for the USMLE Step 1 and Step 2 examinations and also for the NBME examinations as well. So Josie's a 35-year-old female. She's currently on birth control. She presents to your clinic reporting debilitating headaches that have been lasting about the past 5 months. She describes the pain as being unilateral, describes the pain as pounding, associated with nausea and some photophobia as well. She states that the pain when she does have the headaches lasts about 2 to 3 hours at a time. Otherwise, she hasn't noticed any temporal association of the headache, and by that it just means that it doesn't happen at certain times of the day or any other or with any clear triggers. And on examination, you don't notice any focal neurological findings. So there are four options in terms of what it could be. First is cluster headaches, tension headaches, migraines, and trigeminal neuralgia. If you need some more time, go ahead and pause this question. So the answer for this patient is migraines. So our patient Josie, she has several findings that make you think it's migraine as opposed to any of the other options. One is with migraines, the first thing that we notice is that unilateral. So migraines, once again, are very common unilateral. Patients with migraines often frequently report a pounding pulsatile pain, and they will also report nausea that our patient reported, and also photophobia. All those symptoms are very classically associated with migraines. And really quickly, the reason we can rule out the other option, so for cluster headaches, the reason we can say it's not that is these patients tend to have a temporal association in terms of when they have the pain, and patients with cluster headaches often have lacrimation, rhinorrhea as well, which we don't see in our patient. Next, with regards to tension headaches, the reason we can say it's not tension headaches is so for a patient, she reports as debilitating pain. Usually, the pain for tension headaches tends to be mild or moderate at best. It tends not to be debilitating. And we can also say it's not tension headaches is because her patient reports that her pain is unilateral. Tension headaches in general tend to be bilateral. And lastly, the reason we can say it's not trigeminal neuralgia, the pain tends to last for a couple of seconds, whereas the pain our patient reports tend to last for 2 to 3 hours. And really briefly, one thing I want to mention is that for our patient, I mentioned that currently she's on birth control. That was just a red herring. Doesn't really apply to this question. But in general, with birth control, what you want to remember is patients who are on birth control are going to be at a higher risk of clots, but it doesn't necessarily apply to this question. So in this slide, I'm going to go through the differential for headaches and some of the important things that you want to know. But before I go into the differential, one thing I want to point out is the reason patients report headache isn't because you have pain receptors in the brain. In fact, there aren't any pain receptors in the brain. The places where you have the pain receptors are in the membranes that surround the brain and the vessels that deliver blood to the brain. Those are where the pain receptors are. So usually it's due to some issues with those regions that cause the pain, not necessarily issues directly with the brain itself, where you don't, once again, have any pain receptors. So just to go through the differential for any patient who has headache, the first thing you always want to think about are tension headaches. This is what causes headaches for the vast majority of the patients, and usually in the situations, patients report this bilateral band tension-like pain over their head. The pain tends to be less severe when compared to when compared to migraines, and usually management for these patients can be with simple analgesics like acetaminophen or NSAIDs, and pain tends to be overall, once again, very manageable. Next, I want to go over migraines. Migraines tend to be also a very common cause of headaches that patients will experience. Like I mentioned earlier, compared to tension headaches, these headaches tend to be more debilitating, and patients are often unable to take part in daily activities when they're having these headaches. Pain tend to be unilateral in nature, and patients have described the pain as being pulsatile or throbbing. And along with the headache, patients will also frequently report nausea, vomiting, photophobia, and phonophobia. And similar to tension headaches, often the management can be analgesics like NSAIDs and acetaminophen. However, for migraine headaches, triptans are also found to be effective. Next, we want to move on to cluster headaches. So similar to migraine headaches, cluster headaches often also tend to be unilateral, but the key defining feature for cluster headaches is that they're also often have lacrimation and rhinorrhea. And the other key thing to know about cluster headaches is that even though they tend to be relatively infrequent, they only account for about 1% of the case of headache, but you'll still get tested on them a lot just because, for whatever reason, NBME examinations or step one examiners love cluster headaches. Another key thing to remember about cluster headaches is that the reason that they're called clusters is they tend to happen in clusters. So what that essentially means is, for instance, a patient might report that every time they have this headache, it tends to be in the morning. So there's some sort of temporal association with these headaches, and that's what they're called cluster headaches. And the last important thing to know about cluster headaches is that often when patients are having cluster headaches, oxygen, giving them 100% oxygen can be very effective. And it's effective in about 80% of patients in helping resolve the pain. The next one I want to go over is trigeminal neuralgia. So, trigeminal neuralgia is just due to stimulation of cranial lobe number 5. And for these patients, they'll report these short bursts of very severe pain. It just lasts a couple of seconds. But the thing that you want to know about trigeminal neuralgia is for these patients, the pain is so severe that often in many cases, if the treatment is effective, a lot of patients can become depressed, become suicidal. So this is very severe, incredibly problematic pain. And treatment for this from a medical side point is carbamazepine, or you can also do surgery. Neurosurgeons can often go in there and actually essentially create more room for cranial nerve number 5 so it's not impinging on nearby structures. Next, in terms of differential, you also want to know about subarachnoid hemorrhage. And classically, patient will report worst headache of my life. They'll come to the ED and say, I've never had headache this severe. And often in that situation, you want to do some imaging like non-contrast CT to evaluate for potential subarachnoid hemorrhage. I think the list above gives you a very good idea of what are some of the most common causes of headache. But just know that this isn't an exhaustive list. There's some other potential things like tumor, infectious processes that can also cause a headache. So in general, when you do have a patient that comes in with a headache or you do see a question about the headache, you want to look for things like, elevated WBCs or weight loss that might make you think of an infectious process or neoplastic process.